You're very welcome to Culture and Engagement and Healthy UCD's first For Women Health webinar. I'm Mark Simpson from the Culture and Engagement team. This trimester, we're running a program of 4 webinars, especially for women on topical issues. So please book the upcoming webinars that interest you. Today, I'm delighted to be joined by Associate Professor Caitríona Cunningham from the UCD School of Public Health, Physiotherapy and Sports Science to talk about bone health across the lifespan. If you'd like to ask a question, please use the Q&A function on Zoom. And after Caitríona's presentation, we will have an opportunity to go through the questions. So I'm going to hand over to Caitríona now. She's going to present for about 15 to 20 minutes, and we'll have a chat afterwards then, hopefully about some questions afterwards. So Caitríona, over to you, and thank you very much.
Thank you very much. Good morning, everybody. As said, Caitríona Cunningham is my name, and I'm delighted to be here for the first of the series of women's health webinars. Now, I suppose just to put it in context and why we're here talking about bone health, to remind you, it's mainly women on this webinar, although we have some men I see, but 1 in 3 women will sustain a fracture related to osteoporosis or fragility fracture over the age of 50. And that's between 1 in 4 men or 1 in 5 men over the age of 50 will sustain a fragility fracture. So it's something that's going to affect a lot of us on this call today, and we need to be aware of it. I'm going to talk about osteoporosis, some risk factors, bone health across the lifespan, how to screen for it, fragility fracture, and a little nod to secondary fracture prevention. Why am I talking about it? Well, I've been working in this area over a long number of years. Myself and 2 colleagues, Ulrich McCarthy and Catherine Blake, developed the UCD Better Bones Programme back in 2012, and we've paused at the moment due to COVID. And I've also been publishing in the area, doing research and involved in some national and international organisations in relation to bone health, more specifically exercise for bone health. So I suppose we're talking about bone health across the lifespan, and it's important to consider that many of us will hopefully live to 100 and beyond now. And our bone is a living tissue. It's not the inert structure that we sometimes envisage. So our bone is constantly being remodeled. It's being laid down, it's been taken away and reshaped. And basically, we lay down bone from age 0. In fact, it starts to happen in utero. But basically, we're laying down more bone than we're taking away up until about the age of 25 for men and until age 30. So you reach your peak bone mass between the ages of 25 and 30. Then you enter this kind of steady state where the remodeling, the bone being laid down and taken away, for a very simplistic view of it, are equal. So you maintain your bone mass, and then you get this rapid, or the slow decline in general across the genders. But when menopause hits for women, you get a rapid decline, and it's because estrogen has a protective effect on bone. So you can often see this quite sharp decline in bone mineral density around the time of the menopause. So osteoporosis is, I suppose, the clinical representation of when we have poor bone health. It's a disease where decreased bone strength and mass significantly increase the risk of fractures. There are other definitions out there. Some of them include a reference to the bone structure and quality. And if you see the diagram, the simple diagram there, you'll see normal bone on the left with nice dense structure. And when it becomes osteoporotic, you get more space, more spreading out of the struts, and maybe thinning of those walls as well, and those struts within your bone. And that honeycomb structure that you see on the right represents osteoporotic bone. So you can imagine that that would be more susceptible to fracture. The other diagram just represents that idea again, that our bone is constantly being in balance, being remodeled, and there's a complex chemical signaling process that controls this. But basically, if this is in sync, we're okay. And then when that changes due to the loss of estrogen after the menopause, you're going to get more decline in bone mineral density. Now, we cannot think of bone without also thinking of muscle, because muscle has direct and indirect effects on bone. The mechanical pull of our muscles on bone is what keeps their density, and bone responds to that mechanical torquing on it. So again, we need to consider that after the age of 30, we're losing muscle mass. Sarcopenia is the age-related loss of muscle mass and function. You will diagnose whether somebody is sarcopenic. Obviously, you'll know by looking at some people that they don't have the same mass as they once had. You'll see your typical age 25-year-old there on the left, age 63, that's a cross-section through the thigh muscles, your quadriceps. You'll see a lot more loss of bone or muscle mass rather, and you may even see fatty infiltration into the muscle. So now, who's more likely, or what's going to put us at risk of getting osteoporosis? Well, there are obviously individual genetic factors. If we live longer, and again, you go back to that diagram and you think if your peak bone mass was age 25, age 30, and that falls off gradually, obviously being older is going to put you more at risk. Being Caucasian puts you more at risk, and being female. And if you have an early menopause, that estrogen drop is going to occur earlier. If you've had a hysterectomy, you're going to get hormonal changes. And again, the medics are better at addressing these issues now. Or if you've missed periods for 6 months or more, excluding pregnancy as a result of over-exercising or over-dieting, again, you're going to get that drop in estrogen and you may lose bone mass. We also need to be aware of medical risk factors, and this list is not exhaustive, but just to be aware, there are certain conditions like rheumatoid arthritis, the disease itself could affect the bone quality, or the treatment with steroids could. Now, again, the rheumatologists are much more expert at controlling this disease with the biologics we have available, and similarly are more aware of the effects on bone. Eating disorder is a critical issue. If we're not absorbing appropriate nutrients and vitamin D and the calcium, our bone is going to suffer. Gastrointestinal disorders, if our body can't take in the appropriate nutrients, so something like celiac disease could affect our bone mineral density, not necessarily. Endocrine disorders, and again, there are multiple other disorders that I'm not even referring to here today. We also need to be aware that the treatment for some conditions can affect our bone as well. Some medicines can increase the risk of osteoporosis, and some are listed there, anticoagulants and some anticonvulsants. And again, some of you may be aware, unfortunately, through having had friends who've gone through cancer, that chemotherapy or radiation can affect our bone mineral density and our bone mass. So people now again being sent for DEXA scans and being put on maybe bone protective medication if they've had cancer. Now, what can we do about it? These are the modifiable risk factors. So are we getting enough calcium or vitamin D in our diets? We have to take care of stress in our lives. Smoking isn't a good idea. Excessive alcohol consumption isn't good for bone, obviously not good for lots of things. And excessive exercise, particularly without the adequate calories to support that. Too much sodium and caffeine, and a lack of bone building exercise. And I'll talk about that now. So ultimately, how do you know if your bone is okay or not? Well, the gold standard is your DEXA scan. And it is recommended that women go for a DEXA scan. The general public guideline is over the age of 50. But obviously, if you've gone through the menopause earlier, you're getting that estrogen drop. And so it would be recommended that you go for a DEXA earlier than 50. But you may need to arrange that yourself. You may not be recommended it automatically by your GP. Some GPs may be aware, others aren't. DEXA scans, multiple scanners available across the country through both the public and the private system. To pay for it privately, it's about 100, and obviously the public system, it's covered. A DEXA scan is also used to measure your muscle mass and fat mass. Some people aren't as aware of that, but we have athletes coming into our Institute for Sport and Health for a screening of their muscle and fat mass here in UCD. Now again, what do the numbers mean? Well, normally when you have a DEXA scan, you'll be given a T-score. And the DEXA scan may be conducted on the common sites are your wrist, your vertebra, or your spine. And you just need to know that the score you get is not an absolute measure of bone mineral density. It's not the grams of mineral per cubic centimetre. It's not the amount of mineral in your bones, but it's comparing your bone to that of a healthy 30-year-old. And it's looking at how far away are you population-wise from that 30-year-old. And if you're sitting within one standard deviation, you're considered to be in the normal range. If you go between -1 and -2.5 standard deviations, you're osteopenic or classified as such. And if you go to well away from that 30-year-old's peak bone mass, over 2.5 standard deviations away in population terms, you are classed as being osteoporotic. So again, you're on this webinar here today and you're thinking, well, where am I? I'm in the general population. Some of you have children though. Some of you may be expecting a child. Some of you have teenagers, young adults at home. You may be a middle-aged adult yourself, and you may have older adults in your life. So do you know whether you're in the normal bone range compared to a 30-year-old? Are you osteopenic, osteoporotic, or has a fragility fracture happened to you or one of your family members or friends? And this influences what we're thinking about doing in terms of bone. So in the younger years, while you're still building peak bone mass, it's about building bone, laying down more bone. In the middle years, it's about keeping the bone you have. And in the latter years, despite your best efforts, you may still lose some bone, but you're trying to slow it down. And you're also trying to prevent that injury that may cause you to fracture. So there are three main pillars to bone health: diet, exercise, and medication, but only if you've been diagnosed as being osteoporotic. And the trigger to start you on medication is one you'll need to discuss with your doctor, obviously, your GP. Again, some GPs better than others, obviously, in this area, and you may need to see a specialist. In terms of diet, and I'm not a nutritionist, but we do have nutrition in our school, obviously, as a topic that students take. But the recommended calcium is 1,000 milligrams per day. And just to put that in context, your average pot of yogurt is about 200. So I would recommend, if you're concerned about your own bone health or family members, that you do an online calcium calculator to calculate how much calcium you're getting in your diet. Similarly, vitamin D, the international units are how it's recommended. Under age 65, 400 to 800 international units per day. 65 plus, 1,200 international units per day. Now there is a maximum there as well, which you don't go beyond. The only way of knowing what your vitamin D levels are to get the serum levels of that, 50 nanomoles per litre. But in Ireland, in the Northern Hemisphere, the Northern European countries rather, many of us will be vitamin D deficient in the winter, and it's being recommended now that we take vitamin D. Protein, 1 gram per kilogram of body weight is recommended. And protein is critical for both your muscle, but also for your bone health. Do you need calcium supplements or vitamin D? Well, you don't if your diet is sufficient. But if it's not, it's worth considering. Similarly, we also need to consider, particularly during pregnancy, because we're also trying to influence the bony growth of the new baby. We want to ensure our vitamin D is sufficient for both the mother and the child and the baby. And during the breastfeeding phase, again, the mother needs to look after her own vitamin D and calcium. But also, you'll be well aware, any of you who've had babies more recently, that the recommendation for breastfeeding babies is that they are also supplemented with vitamin D, because breast milk may not have adequate vitamin D. Now, my area, which I'm trying to shoehorn into, I suppose, 2 or 3 slides today, is the area of bone building exercise. But rather than going over the ifs and buts, I'm going to give you some takeaway messages, I guess. We know that for bone to build, we need activities that are sudden high strains in diverse and unusual strain distributions. So it's about having impact on the bone, or your muscle pulling on the bone to exert a mechanical pull. So exercises, programs that combine odd or high impact activity with high magnitude, and that's important. It's not just doing light weights. Obviously, you have to build up to higher weights if you're not currently resistance training, but it's about increasing the loading sufficiently to stimulate bone. And we do know that children who are very active and do lots of impact sports like basketball, volleyball, or any of the team sports and running, they have a better chance of having good bone as they turn into adults. So in this single slide, I'm summarizing an awful lot of research, but basically, and an awful lot of literature that's out there rather. For bone health, you need what we call resistance or strength training, and it needs to be at a sufficient load to stimulate the bone. And we need impact exercise. And by impact, we mean stepping exercises for the lower limb. Running is going to give you greater impact than walking. And for the upper limb, you might be doing things like, push-ups, press-ups, clapping, throwing exercises where you're catching maybe a heavy ball, and exercises that are really going to generate that muscle pull on your upper limb muscles to stimulate the upper limb bones. Interestingly, as we consider our muscles from a sarcopenia or a muscle mass loss over the age or our lifespan, we also know that strength training is recommended. So I think this is a really important message, that women and girls should be strength training, and it's important to put that message out there. Now, the question you always get asked is, should you be walking, or is walking okay? And I mean, walking is always good. It has lots of health benefits. In terms of aerobic exercise, you may not be getting your heart rate up high enough to get those benefits. But in terms of bone, it's important to say that you probably need more than walking to stimulate bone. So running is going to be better. But again, if somebody's not taking much activity at all, or say they've been sick for a period of time, like an elderly parent, of course walking, which is a step up from that, is going to stimulate the bone. But if you're already walking around the place, you need to do more than walk for your bone health. And I suppose that's the message. So we could all have fragile bone, and we can live with that. We don't even know we have fragile bone or osteoporotic bone. But our challenge is if we have an incident or there's a process over years that causes our bone to fracture, and we have what's known as a fragility fracture, where our bone breaks without a lot of trauma. And that could be simply you fall from just a standing position and you trip and you fracture your wrist, which is often the first sign people have that they've osteoporosis. In the past, people never had a DEXA scan. They never knew that osteoporosis, but they break their wrist and then they need to consider, was the trauma there sufficient really to have caused a wrist fracture if my bone was okay? And that's often the sign that you have osteoporosis. Hopefully we're getting better as a society. We're having DEXA scans earlier. Other common fragility fractures are vertebral fractures and humeral fractures, which is obviously your humerus is in up at your shoulder, and then ankle fractures. And then in latter years, around in your 70s, hip fracture. The average age of people fracturing their hip, I think, is about 77 in the hospitals in Ireland. And then I put up this slide because I think as a young clinician, I saw lots of people with wrist fractures. And my main concern as a physiotherapist and as an orthopedic specialist at the time, their main concern was, let's get the movement back, fracture fixed, and nobody talked to the person about their bone health. Nobody talked to them about should they be on medication to prevent another fracture. So there's now a global campaign to try and prevent the next fracture. Ideally, we should try and capture someone's bone on a DEXA scan so we prevent the first fracture. Failing that, if somebody has a fracture, they need to be investigated, and we can almost presume if they had a very simple fall that caused a fracture, a very minor trauma, that they are osteoporotic and they need to be on medication for their bone health. One of the critical issues, I suppose, and learnings as well from our Better Bones exercise and education program was that some people came to the program, and often they were the more educated, and they were deciding that they would use exercise and diet as a substitute for medication, and that's not okay. So you don't need to be on medication unless you're osteoporotic and have been diagnosed as such. Exercise and diet is required for all, but you do need to take that multi-pronged approach if you are osteoporotic. The medications, just to put them up here in front of you, and again, this is not my area to be prescribing medications, but it's important we're aware that there are different categories of medication. And if you believe, or if you've been told you're osteoporotic, you do need to discuss this with your doctors to see should you be on any of the following. Some of them are preventing the resorption of bone. Some of them are more focused on the anabolic or more on building bone, and some of them are given after you've had a fracture. You also have options. Some of them you take as an oral, just as a tablet, and then ones like the denosumab is an injection every 6 months. And certainly for people who find it difficult to remember to take medication, your older individuals, that's a very convenient way, the injection every 6 months. These all have different mechanisms by which they bring about positive effects on your bone. And this is something you need to discuss with your doctors. Hormone replacement therapy is something to consider again in that postmenopausal phase. But again, there are some side effects, there are some risks, and it depends on what other menopausal symptoms somebody might be having. So people do need to discuss this with their doctor, but it will provide a bone protective effect. From a physiotherapy perspective, and I'm putting this up here because I am a physiotherapist and I'm only part of a multidisciplinary team when it comes to take care of fractures. But again, people come with multiple issues, and also some of the other areas when it comes to exercise that concern women in particular are that you may have issues like stress incontinence that makes some of the impact exercises more challenging. So that's something that physiotherapists also support people with addressing. We may be working with people who have respiratory issues, who fractured a vertebrae. And again, we're very experienced in working in that area. Somebody may require a brace, although the evidence is out for people with a vertebral fracture. They're generally not recommended because most vertebral fractures do not require a brace. But you may have relatives who can prescribe them, and it's worth discussing the necessity for it. And obviously frailty, unfortunately, this osteoporotic fracture is often part of an overall picture of a frail, older, vulnerable person who sustains a fracture. And again, it's about mobility, it's about exercise, it's about having appropriate diet to combat that frailty. And I suppose a word of caution, when we talk about exercise to build bone, if your bone is still healthy, you can proceed with all the impact and the high resistance training. If you are osteoporotic, and in particular, if you have sustained a fragility fracture, a spinal fragility fracture, there are some activities that do need to be avoided. So those loaded activities where you're rotating your trunk with weights, you would avoid certain machines in the gym. Some machines are fine. Something like your lat pull down wouldn't be recommended where you're straining your neck. But again, if you have osteoporosis, you would benefit from getting guidance from a physiotherapist just to get you going, and then often do your independent exercise once you know the do's and don'ts. Again, we work a lot with people, teaching them how to lift, how to avoid certain things if they're osteoporotic or have a fragility fracture. But it's still very important to exercise even if you are osteoporotic, and that's a key message. There are just some do's and don'ts, but exercise is still critical, and the focus may switch a little to maybe the medications having the more powerful effect on the bone, but that it's really important that you exercise from the muscle to improve balance and to reduce the risk of a fall or an incident. So I'm just putting down here that we cannot manage osteoporosis without the input of a number of health professionals. I'm just listing some of the people who might be involved. If you're concerned about your own bone health, your GP is your starting point, obviously, and you may or may not need to be referred to any of these other individuals. I obviously would say it, wouldn't I, that it's a good idea if you are osteoporotic to get some guidance and exercise to get you going and then move to independent exercise. So the take-home messages from today: if you're young, the focus is on building bone through a good diet and exercise. The middle years, again, you need to be building bone, diet and exercise. Have that DEXA scan around the time of the menopause, age 50 or younger for some women, obviously. In the older population, diet and exercise, you can always build more muscle, you can always influence bone. But again, the focus of the exercise may switch more to balance training as well, strength training to prevent a fall. If you're diagnosed with osteoporosis, you do need medications. Continue with the appropriate diet, exercise with some exercise precautions. And if you're in that more severe osteoporosis where you've had one or more fragility fractures, again, medication, maybe a more anabolic form of medication, diet, exercise with more precautions relating to that exercise, and weighing up the risk benefit of certain types of exercise and activity. So thank you for listening, and I'll take your questions and answers.